And we are excited to have today with us Professor Soichi Oya from the Saitama Medical University, Saitama. Professor Oya is a very well-known public figure in neurosurgery. He has several publications, the latest of which is Spinal Artery Aneurysm, which he published in the Neurosurgery Focus. It was an exciting video. Professor Oya is the official translator for the Operative Neurosurgery Journal as well as the Neurosurgery Journal. He is a great academician and clinician. Professor Oya, on behalf of the ACNS Education Committee and Professor Yoko Kato, the president of ACNS, I welcome you to our ACNS webinars. To chair this session today, we have Professor Naoki Otani, who also have been our previous speakers for the ACNS webinar. Professor Naoki Otani from the Nihon Medical Center, I hereby welcome you to chair this session. Thanks for coming. Professor Soichi Oya, you may please start your presentation.
Okay, thank you very much. Good afternoon and good morning and good night, everyone. Okay, I'm gonna share my screen. Looks good?
Yeah, looks good, Professor.
Okay. So again, hello everyone. My name is Soichi Oya from Saitama Medical University. And today I'm going to talk about the skull-based techniques for cerebral aneurysms. The technique I'm going to show today is nothing fancy. However, it's very important, very critical in the treatment of cerebral aneurysms. Okay, now it's the era of endovascular surgery. And you know, as we all know, it has been playing the pivotal role in aneurysm treatment. However, I think the open surgery still is required, need for some selected cases. For example, you know, MCA aneurysms are good candidates. All the previous literatures to date advocate the open surgery over endovascular surgery. And also large to giant aneurysms arising at the non-ICA intracranial arteries. In addition, however, the extremely small aneurysms with wide neck, including the broad bristle-like aneurysm. And in addition to these aneurysms, today I'm going to focus on some specific cases like ICA aneurysm causing visual deficits, and aneurysm requiring sacrifice of the parent artery. And also I'm going to talk about some aneurysms in young patients requiring complicated endovascular procedures. These characters, these sentences highlighted with pink color, these are the reason to choose the open surgery. Before I start the case presentation, let me begin with explaining the rationale of our orbital zygomatic approach. So the question is, when do you need orbital zygomatic approach? My answer is when you want to have a lookup view with minimal brain retraction. So this is the orbital zygomatic, you know, the direction. So the indications include craniopharyngiomas or high-positioned basilar top aneurysms or high-positioned ACOM aneurysms from a trigonal approach. In my opinion, the meningiomas, we don't use the, not frequently use the orbital zygomatic approach because we can use the space that's already being created by tumor itself. So the first case is a high-positioned basilar top aneurysm. This was a ruptured case. This patient was a 66-year-old lady. She had a subarachnoid hemorrhage. As you see here, that the aneurysm was formed at the top of the aneurysm. The definition of a high position is said to be the 10 millimeter or higher from the anterior crinoid and the posterior crinoid line, which is also called the ACPC line. This case, the distance from the ACPC line to the neck of the aneurysm was 18 millimeter. So what we utilized the orbital zygomatic approach, the macroscopic part was already done. And now this is a right side approach, and I'm cutting the meningoorbital band. And also I'm drilling and open the superior orbital fissure. Look here, the optic canal roof is extremely thin. Sometimes we encounter this type of optic canal. And we just added a slight drilling of the optic roof. And also I'm removing the anterior crinoid process. If we have some difficulty to removing the anterior crinoid process, let me advise you to add a little bit drilling on the optic strut. And then I open the dura. And I think having the radial view to the aneurysm is important to look up the aneurysm. And for this purpose, I think cutting the arachnoid, covering the middle cerebral artery, the veins, superficial middle cerebral veins, or MCAs, or anterior temporal artery, that's critical. Now I'm cutting the thick arachnoid, covering the cerebral veins. By cutting this thick arachnoid, I can get this view. This is the terional view. If you have a correct direction, the M1 should come in the center of your operative field. Now this is the optic nerve. This is A2, and also removing the clot in the subarachnoid space is very important. And by isolating these vessels, including arteries and veins, now I can retract the temporal lobe posteriorly like this. Look at the tip of the retractor. This is onto the contacting the tentorium. And the next step is to cut the distal dural ring. By doing this, I can mobilize the ICA medially, and so that I can expand the space posterior to the ICA, which is also called the retrocarotid space. You may encounter some bleeding from a cavernous sinus by cutting the distal dural ring. But now, I'm starting retracting the temporal lobe posteriorly. And the next step is to cutting the thick arachnoid membrane covering the oculomotor nerve. By doing this, you can untether the temporal lobe, and also you can free the oculomotor nerve. And this is the ipsilateral SCA, basilar trunk here. Now, I'm retracting the ICA like this. And now I'm confirming that I could put the temporal clip onto the basilar trunk. And I just simulated the insertion of the clip. This is the PCOM and the P1 and P2 junction. And this is the dome of the aneurysm. Look, you can create the ample space here. And then I apply the temporary clip, and I also protect the ICA, and I put the retractor here. Now I could use the both hands, and I'm checking, exposing the neck. This is a perforator, and now I'm checking there is no perforator around the neck. And I insert the small mini curved blaze clip here. Once you create a wide ample space here, the clipping is not formidable, difficult. The perforators are preserved and they look good. And the intraoperative video angiography showed disappearance of the aneurysm and a good patency of the P2, both P1. And the MAP was fine. And at the last step, in Japan, we frequently use the cisternal drainage to control the intracranial pressure. So I put the cisternal drain here. So the postoperative imaging showed complete disappearance of the aneurysm. So next, I'm going to talk about the ICA aneurysm causing visual deficits. To prevent the rupture is very important. However, we also have to improve the neurological deficits. For this type of aneurysm, I think the endovascular surgery has been unsatisfactory yet. So for some selected cases, I think the clipping may be a useful solution. And this patient was a 77-year-old lady complaining of a left side visual deficits caused by the ICA paracranial aneurysm here. So this is the left side approach. And, let me show you how I confirm the location of the aneurysm first before I actually perform the extradural drilling of the sphenoid bone. And then I'm drilling the sphenoid wing. And, I can just repetitively check the location of the aneurysm like this. And now, I'm dissecting the aneurysm here. This is the optic nerve. This was the discolored portion. And this is the distal part of the ICA. And now I'm coagulating the dura covering the optic canal. And you have to be careful when drill this portion because the, right underneath this bone, the optic nerve is running. And also this has been already damaged by long-term compression by the aneurysm. This is the falciform ligament. And by carefully opening the falciform ligament, you can see the dent here. This is the most vulnerable part of the optic nerve. And now I'm trying to create a space here, and do not hesitate to removing the dura in this portion, because in the first place, it's impossible to close the dura in a watertight fashion here. So all you have to do is to repair the paranasal sinus. And by removing the dura, you can get the wide space here, and everything is clear. And before starting the dissection from the aneurysm of the optic nerve, I put a temporary clip here, and also I clamp the cervical ICA to reduce the pressure. And I try not to push the optic nerve. I try to be gentle as possible. And I apply the first clip, but this was too close to the neck of the ICA, the aneurysm, close to the ICA, so I chose to the second clip and remove the first clip. And there was no inflow confirmed into the aneurysm. And complete obliteration. Unfortunately, her visual field cut did not improve after surgery. However, her visual acuity improved from 60/100 to 90/100. For this surgery, we utilized visual evoked potential, VEP. While I secured the space between the optic nerve and the aneurysm wall, I clamped the cervical ACA. While clamping the cervical ACA, the amplitude of the VEP has decreased on both sides. This is control. However, it recovered immediately after declamping, which means this decrease of the VEP amplitude is not from the mechanical injury to the optic nerve while dissection, but from the temporary ischemic defect. So we're using this evaluation repetitively, while dissecting. We were sure that we were on the right track in dealing with the optic nerve. So I think this reassurance is good for surgeons' mental health, right? So our key techniques for ICA aneurysms causing visual deficits, I think, are anterior cranioidectomy prior to manipulating the optic nerve to reduce the additional damage, and minimal dissection of the optic nerve. And also, if possible, in some cases, visual evoked potential monitoring is helpful. Next topic is the aneurysms requiring sacrifice of the parent artery. In this regard, I think the broad bristle-like aneurysm or ICA, anterior wall aneurysms, are very well known. However, today I'm going to show a case of fusiform aneurysm of right side superior cerebral artery, showing their interval growth over 5 years from 3 millimeters to 8 millimeters. Considering the disproportion of the size of the parent artery and the size of the aneurysm, I think it indicates that the higher possibility of the future rupture. So where we had the thorough discussion about the treatment options, our endovascular surgery team said that they have had to sacrifice the right side superior cerebral artery. But in literature, some ischemic symptoms can occur by sacrificing the SCA because of the occlusion of the perforators from the SCA to the brainstem. So we had a discussion with our patient, and she chose to have the open surgery consisting of the SDA-SCA bypass and the trapping of the fusiform aneurysm. For this surgery, we chose the anterior transpetrosectomy using the extra and the intradural approach. So the patient was placed on the supine position, and her neck was rotated to the left. And this is a two-layer dissection, and the transzygomatic approach, and the temporal muscle was reflected as lower as possible. This is the supramastoid crest, which corresponds to the height of the tegument of the temporal bone. This is the facial heariness and the GSPN. I'm checking the course of the facial nerve by facial nerve stimulation. And this is the so-called Cavus's lombard. And now I'm drilling the Cavus's lombard. And when I complete about 80 or 90% of the drilling procedure, I just open the dura covering the temporal robe. And using the space I have already created, I cut the tentorium. And you see here, this is the fourth nerve. And I'm exposing the fourth nerve, and I moved anteriorly, and I found the ICA. And this is the oculomotor nerve. And this is the proximal SCA. and the aneurysm is here. And this is fourth nerve again. And the next, I cut the tentorium a little bit more, and I removed the, I drilled the last tip of the petrous apex. So as you see here, by drilling the, the petrous apex, I could obtain an ample space for making anastomosis. By doing this, I think, as you see here, we can avoid the too much retraction of the temporal lobe. And also, for this type of deep anastomosis, I think it would be advantage if we can lay the donor artery from right or from left, like this, so that we can enhance the visualization of the site of the anastomosis. And also, you can have, ample space to insert surgical instruments from various directions. Now I'm releasing the apparent artery flow. And I apply the clip, permanent clip to the distal to the aneurysm. And ICG video angiography showed a good patency via the donor artery. And the last step, I added the clip, another clip to the proximal portion of the superior cerebral artery. And she had no infarction, fortunately, and the postoperative 3D CT angiography showed the bypass vessel here. So for aneurysms requiring sacrifice of the parent artery, I think reconstruction of the parent artery should always be considered. For SCSCA bypass, I think intradural anterior petrosectomy provides a better angle for bypass instruments, also mitigate the temporal lobe retraction. We reported this case to the Journal of Neurosurgical Focus, and we showed the significant increase of their working space here. I think the endovascular surgery is the treatment option for most aneurysms. However, for some selected and complicated aneurysm, clipping may provide much simpler and a more definitive solution, especially for young patients. So this patient was a 40-year-old lady who had subarachnoid hemorrhage due to the ruptured VA union aneurysm here. And this aneurysm project anteriorly and posteriorly is very complicated aneurysm. And it's not easy even for endovascular surgeon to obliterate this aneurysm. So we chose the direct surgery consisting of a combined transpetrous approach. Combined means the combination of the transcondylar approach and the posterior transpetrous approach. So this is condyle. And then I am removing the root of the condyle. And this is the condylar emissary vein, which was nicely controlled. This is the hypoglossal canal. And after this part is done, I moved to the transpetrous approach part. This is the antrum and the lateral semicircular canal here. Let me emphasize that for vascular surgery, I think aggressive drilling is important because you may need a little bit more wider, space to accommodate the clip or temporary clip or larger suction tube. And in case you have massive bleeding while you're dissecting the aneurysm or something like that, you have to draw these parts. And this is a facial nerve. And also I open the internal auditory canal here. And this will, teach what kind of nerve around here. That this is the fifth nerve. So the vasovagal trunk should be ventral to the fifth nerve here. So I think I will be able to secure the vasovagal trunk when I have to, temporarily occlude the vasovagal trunk. And now I open the dura and I cut the arachnoid under. This is a lower cranial nerve. And this is the eighth nerve and the seventh nerve behind the eighth nerve. And this is the proximal portion of the VA. And now I'm approaching the aneurysm. Aneurysm is here. This is the ipsilateral VA. This third portion of VA. This is the beginning of the aneurysm, this linear part. This is the surgical view. Now I'm preserving the perforators. These are very important perforators. And look, I applied the retractor on the brainstem. I know, we have to normally we should avoid this type of usage, but to create the space here anterior to the brainstem, I had to do this. And this is the portion of the left loop here. My plan is put the first grip to close the left half of the neck together with the left loop structure here. Now I'm applying the first grip to creating the closure line half here. By doing this, I could get the additional space to cut the arachnoid and confirm the perforators around the aneurysm. And I cut the arachnoid close to the right side of the aneurysm neck. And next I use the fenestrate grip to jump the first grip and close the right half of the aneurysm neck. And as for monitoring, we use the MAP and SCP for this surgery. This is clot, and this is also clot inside the dorm. The ICG showed the obliteration of the aneurysm. This is the right half of the ring, and the post-operatively it looks good, and she was discharged with no neurological deficit. And this is the last case. She also had a subarachnoid hemorrhage. She was young and ruptured VA union aneurysm. But in this case, the location was a little bit higher than the previous one. So we chose the posterior transpitural approach only. And from this approach, from this case, I like to emphasize the importance of preservation of the venous drainage. So this is the left side approach, temporal lobe here, and this is a posterior fossa, mastoid process. I'm starting with a mastoidectomy. This is the antrum. And this is the endolymphatic sac. And I coagulate the orifice of the endolymphatic sac and I cut it. And this is the lateral semicircular canal and the posterior semicircular canal, superior semicircular canal. And I drilled the tip of the bone here. And now I'm confirming. You see here, this is the sigmoid sinus, which is patent. And again, I'm trying to preserve this flow, petrosal vein, superior petrosal sinus, and the sigmoid sinus. Excuse me. So try to preserve the route of petrosal vein. I cut the superior petrosal sinus at the anterior portion. And then I'm, approaching the basal trunk. And to accommodate the clip head, I need to open the internal auditory canal too. And now I'm identify the, this is the distal basal trunk, and this is the aneurysm. And I'm isolating the perforators here. Look, you can have a wide space here. And now I'm confirming the venous return is preserved like this. So the aneurysm was gone. For these types of complicated vascular trunk aneurysm, I think craniotomy can be a definitive treatment, especially for young patients. And combined transpetrosal approach provides safe access to the proximal or the distal basal trunk aneurysm, which is one of the basics of the aneurysm surgery. And it also provides ample working space, even for the location around the basal trunk. These are all presentations I prepared for today. Creating a wide working space using a skull-based technique is very important to enhance the safety to treat these aneurysms. And the clipping is still important option, especially for young patients. Thank you very much for your attention.
Thank you. Thank you very much, Professor Oya. It was an exciting presentation. So beautifully you have demonstrated all the skull-based techniques. Really fortunate to have you here today. Professor Otani, would you like to comment?
Yeah. Hi. Thank you, Professor Oya, for your showing the excellent technique for the skull-based techniques. So may I ask a question?
Yeah, of course.
So yeah, also so in second cases of the paraclinoid aneurysm, I think it might be the carotid cave aneurysms, right? So how is the visual function after the operation? Because I am afraid to the visual acuity will be worsening, because that in the cases adhesion of the between the aneurysmal dome and the optic nerve is so severe.
Okay.
So I usually I might worsening the visual acuity will be worsening. So to detach only the detach the aneurysmal dome from the optic nerve. So do you think, how do you think about that cases? So in your cases, so it's just subarachnoid hemorrhage. So I think it's so we have to secure we have to save her life. But in the unruptured cases, so I will ask, so do you think about that cases? So
Okay. Okay. Thank you. Thank you for asking.
thank you.
As for the location of the aneurysm, I think that's not the carotid cave aneurysm, slightly distal to the carotid cave. So I think I would prefer to call paracrinoid aneurysm. And you know, that was the second case was an unruptured case. So we did it to, you know, aiming for the visual improvement. And of course, as you pointed out, we had a discussion with our patients about the risks of visual, you know, worsening. However, at the same time, the treatment result outcome of the endovascular surgery is not that good. So yeah, we had this discussion, and the key technique to preserve or improve the visual function for this type of aneurysm, I think, like I showed, we have to decrease the pressure to the optic nerve as soon as possible, even during surgery, by removing the optic canal roof before we actually dissect the aneurysm from the optic nerve. And also we have to reduce the pressure by trapping the ICA, intra-aneurysm pressure. And then I know my comment is a little bit controversial, but I try not to dissect the aneurysm wall from the entire course of the optic nerve. All I have to get is the place to, you know, insert the clip brace. So if I dissect the aneurysm excessively, that might injure, that might cause the visual worsening after surgery. So if I think I could obtain the enough space, I will stop it, and I will move to the clipping of the aneurysm.
Thank you.
Thank you,
Professor
Kanan. Thank you very much.
Thank you, Professor Otani, for asking. I would like to say to Professor Oya that the visual outcomes following clipping of paracrinoid aneurysms is dealt with extensively in the literature. In the present Asian Journal of Neurosurgery, there is an article written by me, which has a large series from Bantane, which is the outcomes of vision following clipping of paracrinoid aneurysms. As you had demonstrated that the patient did not improve the field cuts, that is because of the long duration of the impingement on the optic nerve.
Right.
The person who wrote it before me was Kamide et al. From the Barrow Neurological under Dr. Lawton. He also has summarized all the literature, and he has also agreed to it that the long duration of impingement is patients who have this long duration are less likely to improve. And also, as you said, that there you showed the visual evoked potentials. I have written about VEP in that article. I have searched extensively, and it is said that VEP is very unreliable in prediction whether there is a visual decline intraoperatively or not. Do you agree to it?
Well, actually, VEP, you know, we cannot rely on VEP to check the mechanical injury. But as for, I think, ischemic injury, like closing the ophthalmic artery or something, sometimes, you know, if it's this was not the case, but sometimes, you know, for you know, carotid cave aneurysms, the ophthalmic artery might be involved within the you know, the closure line, and in the case, I think a VEP can be helpful. But it's not good to detect the mechanical injury.
Right. Professor Imad Kannan is with us from Saudi Arabia. Professor Imad Kannan, would you like to tell your comments, sir?
Hi, how are you? I wish I was able to join you from the beginning, but I finished on time, and I thought I should join you on this events. I'd like to commend Professor Shoichi. Where is he? I don't see him now. Fantastic presentation. Hello, how are you?
Hi, good, thank you. How are you? You look good.
A wonderful presentation, and I learned a lot. You have much more experience in the vascular than me myself. But I think for the educational part, or perhaps if you can comment on the timing for the temporary clip, this is one, and for the neck temporary clip, and how you are guided if you have to apply the temporary clip on the last case, the basal artery aneurysm. Do you do suppression? Do you do on the giant one, the other question, suction decompression? These are some of the questions I thought. The others, they are shy to ask you, but I thought you might give a comment on this one.
Okay. Are you asking the duration of the temporary clip?
Yes.
Okay. Okay. So for ICA, I usually limit my time of temporary clipping as 5 minutes. But yeah, in every case, I use the MEP. And if there is no sign of ischemia, no sign of motor paralysis, I may extend from 5 minutes to 8 minutes or something, but never extend to 10 minutes. For basilar artery, my experience is kind of limited, so I think I'm not qualified to make any comments. But how about you? I think.
No, my experience, I told you, is less than yours. But you showed the challenging cases of the basal artery. They are not an easy cases to do, but you performed well. Now, it means for the middle cerebral artery, you are guided by some kind of neurophysiological changes. You check, you have motor evoke potential or somatosensory evoke potential to be guided that there is some, you said there is some changes in the motor function. How you are going to check it? It's a neurophysiological, isn't it?
Yeah.
Yeah, that's what you do. You do.
Yeah. For anterior circulation, surgery, I only use the motor evoked potential transcranial.
This is a very good.
Right. But for posterior circulation lesions, I also use SAP. But just in case, I'm not I'm not putting too much priority on the SCP.
Yeah. The other small trick sometimes I use, and I learned it from Professor Yashagi many years ago, the on-off temporary clip. So you put the temporary clip, if you, as you said, past the 5 minutes, open it while you are not still dealing too much with the aneurysm dissection. And then when you are near and need some of the perforator, they are attached to the dome, then I reapply it again. So this is the on-off technique. It's a very helpful technique.
Yeah. I think I'm using that too. Yeah.
I'm sure you'd use it with the subconscious. It's natural.
Yeah. Right.
Well, wonderful to see you and a wonderful presentation.
Thank you. I'm happy to see you here. Yeah. Thank you.
Thank you, Professor Imad Kannan. One more thing which is to be mentioned is that before using the temporary clip, what sort of neuroprotection do you use? Because in our setup, we usually use preoperatively, we stick the BIS, that is bispectral index, for monitoring, because we do not have MEP and SCP here. So depending upon the BIS, before temporary clipping, we bring down the BIS to around below 20, and then we apply the clip. Usually we use thiopenton. So what do you use in your place? Do you use BIS? You obviously use MEP and SCP. No,
MEP, SCP. I'm not using BIS, and I know some people use some medication like called it's the Japanese pharmaceutical company. It's called Lajcat. It's like a free radical scavenger to reduce the hazardous effect from reperfusion. But I think it's not that popular, and I'm not using any medications to increase the protective effect. Only physiological monitoring.
Right, thank you. Professor Kalangu, Professor Kazadi Kalangu, would you like to comment, sir?
Yes, thank you very much,
Thank you.
Professor Soshi. Thank you very much
Thank
for
you.
giving me the opportunity to talk. And congratulations to Professor Soshi.
Thank you very much. I'm
Professor
losing your
Kalangu,
voice.
You are muted, Professor Kalangu, please.
Can you hear me now?
Yeah, we can hear you. Please, Professor.
Okay. I was saying congratulations to Professor Soshi for this wonderful, excellent presentation. We always learn a lot, you know, from each other, and I've learned a lot also myself. I think this is really a fantastic, you know, presentation, and a fantastic topic as well, because it was presented so easily. But the students, they should also realize that it's not that easy operation. It looks very easy, but it's not that easy. So you need really to have somebody who can be nearby, who can mentor you, and who can teach you exactly how to do it now. One of my questions is, how do you prevent vasospasm in your patients?
I think, you know, usually like I said, I put the cisterna drain to control the intracranial pressure.
Okay.
And also during surgery, I try to remove the clot in the subarachnoid space as much as possible. So that's the big, in my opinion, that's the biggest advantage compared to the endovascular surgery.
Okay.
You know, not only clip the aneurysm, we can remove the clot. That's another important, you know, role over direct surgery.
Okay.
Thank
That's
you,
fantastic.
Professor.
Yes. Thank you very much.
Thank you.
Professor Kalangu's own student, Professor Aaron Mushara, who was with me, he wrote this article about high riding basilar artery and clipping. So during his time when this, it is there in the AGNS, I think the previous issue. So when he wrote this article, we had extensively searched about indications. And once Professor Takizawa was with us, and we asked him that he clipped that aneurysm, and he did not take off the zygomatic arch or orbitozygomatic. It was a frontotemporal craniotomy. So he was under the opinion that he never uses this technique of orbitozygomatic, because he always retracts the temporal lobe and extensive arachnoid dissection, and he unlocks the brain axially and then clips it. So, and also one more question regarding OZ is that have you had any complications for visual decline following orbitozygomatic craniotomy? Because this is often a cited article from King's College London by Christopher Tolias, who wrote that he had a case of blindness following external pressure to the eye during orbitozygomatic craniotomy. Do you have complications?
Oh, you mean the visual worsening caused by the eye pressure?
Yeah.
I think, yeah, I have heard of it, but not in the case of OZ approach, but from the bicoronal approach, you know, bicoronal skin incision. And that may, you know, push the eyeballs, you know, too hard, resulting in the visual loss.
Possible.
Yeah.
Professor Ajit Sinha, would you like to come in? Professor Ajit Sinha?
Yeah, yeah.
Please,
first of all, very congratulations for an excellent presentation and technically perfect. But Professor, I would like to ask you one thing. Am I audible?
Yeah, you are, sir. Please go on.
Yeah. So I want to ask, like, nowadays is the era of, you know, a lot of advancement in endovascular procedures. And the endovascular surgeons, they always say that they can do everything. Like, I'm a neurosurgeon, I have a training in endovascular as well. So I just want to ask you a few questions, like, like the the fenestrated vertebral artery aneurysm which you showed and you clipped very nicely. But being an endovascular person, somebody will say now P-conus is available, and by using the P-conus, you can easily and very safely coil such aneurysm. Mm-hmm. So in your setup, how do you, how do you make in harmony with the endovascular guys? How do you decide that this should go to endovascular and this should go to surgery? Like nowadays, all these paraclinoid aneurysms, they are treating by flow diverters, and
right.
they say that it is the most safe. So, your opinion?
Thank you. Yeah, thank you for your nice question. That that's all. I think the boundary, I mean the territory of the open surgery and endovascular surgery is overlapping. But if it's feasible, endovascular surgery is feasible. I think it should be the first treatment. That's my opinion. But the point is, I think the most important thing is to have a nice partner, who specializes in the endovascular surgery from the standpoint of the open surgeon, craniotomy surgeon. And we just discussed, and we all know the limitations of both approach. And then we just, add some other informations like, the young patients who may require long-term platelet therapy, which is not good for young patients, basically. And if you have a good skill of skull-based technique, you can create the ample space like MCA, even now the ICA, or even other vertebral artery, aneurysm. And so discussion with such partners is critical to make a correct, decision. And it should be like towards the more craniotomy line. It might be, sway to the more endovascular line. It depends on the institution. I think there's no definitive, solution.
That is most important.
Oh, you're
seeing the case for the first time. Like for you, I'm sure all aneurysms you can easily clip. And but for endovascular people, they again can, they can say that they can put flow diverter in most of the paraclinoid aneurysms, and the aneurysm will disappear. They'll come out with some data. So what do you see in future? What is the future of the paraclinoid aneurysm surgery?
Well, I guess the patients will decide it, and the patients will prefer the endovascular surgery.
Right.
Okay. I know, they like less invasive treatment, so they will be decided by patients, But I believe that especially for large paracranial aneurysms, not small one or medium one, large paracranial aneurysms causing visual deficits, I think still the open craniotomy has an important role.
Okay, thank you.
Okay, do I make sense?
It was an excellent presentation, and very difficult cases you have shown, and obviously technically perfect presentation. Thank you.
Thank you. Thank you for your comment.
Thank you, Dr. Sinha, for coming. Professor Imad Kannan, would you like to take a question about what is the future of endovascular surgery and open surgery in paraclinoid aneurysms? Professor Imad Kannan is muted, I think. Professor Imad Kannan, I think he's talking to somebody else. Professor Hidehito Kimura is here. Professor Kimura is also an official translator of the neurosurgery.
Yes, I'm here.
Neurosurgery here.
Oh,
please,
Sensei.
Hello. How are you? So it's Professor Oya.
How are you?
Yeah, thank you. Nice to see you here. How are you? You're still the
good.
So COVID outbreak. Yeah. How are you?
It's for the first time in 6 months. Oh no, 10 months or something.
So long. Yeah, still in Tokyo, so many patients is suffering. COVID pandemic.
Still the numbers increasing.
I'm just worrying about you.
I'm okay. Thank you.
Thank you for your nice presentation. And I absolutely enjoyed your presentation and sharing your excellent surgical skills. Yeah, your surgical skills are always so fine. Yeah, I'm so surprised, always surprised. And this is my, thank you. This is my question and a comment. So what is important in treating the paracranial aneurysm? I also thinking about how to preserve not only the ophthalmic artery, but also the superior hypophyseal artery.
Okay.
Yes, in your video, I can detect the superior hypophyseal artery, but however, the patient preserved the visual acuity postoperatively. So how do you comment about this question? Matter?
But in that case, I made my best effort to, look for the superior hypophyseal artery around the neck. I just omitted that part from my movie, but in that case, I couldn't find, the noticeable superior hypophyseal artery, so I just put the clip. But based on my experience, like not only aneurysm, but also craniopharyngiomas. And there's a paper showing the structure of the superior hypophyseal artery. In most cases, it's creating the circular structure. So if you, cut or occlude just one part of the circle, that might not necessarily mean the complete occlusion of the superior hypophyseal artery. I'm a believer of the theory. I'm not sure if it's true for all the patients, but so if of course I make my best to find the superior hypophyseal artery, but if I cannot find, I'm not so keen about finding it.
To achieve the best confirmation intraoperatively superior hypophyseal artery, the full circumferential incision around the distal dural ring may be more important. Maybe so. Sometimes we may encounter the ophthalmic artery incision around the distal dural ring. It may be maybe sometimes cause the problem. So my second question is, VEP is very, very effective for the treatment of the paracranial aneurysm, but I think the postoperative delayed deterioration may occur sometimes to the patient. In the VEP, we can't detect the postoperative delayed deterioration, maybe caused from the ischemic event. But yes, so how do you have some comment to this problem?
Right. I have heard the case, lots of cases with the delayed onset of the visual worsening after surgery, but I personally have never had the experience.
Oh, I see.
So maybe my speculation is that I always try not to, occlude the cavernous sinus too much by, inserting the like hemostats, like a gel form or some other
ocular congestion due to the congestion.
So otherwise, it cannot be explained, or maybe vasospasm, the arterial vasospasm, but it's more plausible. I think venous congestion from the too much packing of the cavernous sinus.
To avoid should be
so I try not to do it. So I'm not sure if it really works. So
thank you for your fine comment. And please keep safe.
You too.
Thank you.
And you all too.
Thank you very much. We are too. Thank you.
Because as you said, keeping anything near that region, any plugging of fat or any material to prevent CSF leak has been found to be a significant factor for visual decline. In the paper which came out from Sapporo about visual outcomes following paracranial aneurysm. So is perfectly right. Professor Imad Kannan, would you like to come in, Professor?
Yeah, I muted myself actually.
Please.
Just to compliment Professor about his recommendation opening the cistern. This is what is many years ago, Professor Yazagil has advised to open not only the cistern where you are dealing, but most of the basal cistern to make it communicate and navigate the clots completely out, because this is the major treatment as part of the treatment of the vasospasm. But I was interested with the drainage he put in the basal cistern. This is always in the same location where he opened the liquid membrane and to drain. This is because it's the major confluent of CSF, or he varies his position. This is one question. The other question, the role of endoscopy to identify the tip of the clip from the posterior part of the aneurysm. Does he have this in common practice in some of the cases?
Okay, as for the location of the cistern or drain, I almost always put the drain into the the parapontine cistern, prepontine cistern, because there's a big cisternal space there.
Sure.
And so that it will probably reduce the possibility of the obstruction, unintentional obstruction of the drain. Some people open their the space. I forgot the name. It's behind the chiasm. Lamina terminalis.
Right.
Lamina terminalis.
Lamina terminalis, yes, lamina terminalis. And I think it also the same idea, I think. But I prefer, even for simple, like a ACOM aneurysm or ICPC aneurysm, I just, bother to open the relicus membrane to insert the cistern drainage there. And the second question, yeah, I sometimes use the endoscope to confirm the location or confirm the complete clipping, but it's very rare because I always try to open widely and I try to make the shallow working space. And I flip the microscope like this, and I try to check directly the tip of the clip, but sometimes in their case.
Thank you.
Okay.
Thank you. Thank you, Professor Imarkan. And I would like to say Professor Yoko Kato is a huge proponent of endoscopy in the use of aneurysm surgery. And they regularly use the endoscopy during to assess the completeness of the clipping. The previous fellow, Professor Dr. Mohsin Noori, wrote a fine article about how endoscopy influences the final clipping and repositioning of the clips. This was a good series from Bantane which came up. One more question about that far lateral transcondylar approach you showed, Professor Oya. Yeah, you showed the drilling of the condyle. So how much do you actually drill the condyle? Because it's very controversial, because in 2016, there came a paper in the JNS from Shiba and et al. Who showed a series of 21 patients who did not have any instability. Even among these 21, there are 5 patients who had condyle drilled more than 75%, and they did not show any instability. A year later, from Salt Lake, Utah, there came a paper from Marcus Mazur, which is often quoted in most of the articles, that he did a study on cadaveric patients in 9 patients, and they have demonstrated that occipitocervical instability does occur after more than 1/3 of drilling of condyle. What is your opinion regarding this?
Okay. Firstly, I was impressed at your knowledge as you were walking dictionary, huh? Okay, so yeah, I probably am not able to answer your question, but I was told by Professor Tomio Sasaki, who is a specialist of skull-based surgery. And he told me medial 1/3 of a condyle can be drawn off. And I just loyally, keep his secrets or his lesson. And fortunately, I've never experienced any, problematic instability after this approach. But probably medial 1/3, which is close to 70%, right? I think that's the safe zone, I think.
I have asked these questions to Professor Takizawa previously when I was there in Japan, and he has always stated, he said that drill as much as you want, drill drill what you want to see. That was his answer. His sentiments are echoed by various online lectures from the Seattle Science Foundation. You can see Johnny Delasho also appears to concur this theory that you drill how much you want to see. What would you like to say, Professor Kannan?
Well, I agree, because it's very difficult to judge how much you drill, first of all. And always the recommendation, the medial 1/3, if it's needed. But I agree with the statement that many of my colleagues in the skull-based surgery say you drill whatever it's needed. And remember, this is still a unilateral approach. I mean, they are talking about instability and all this, but it might give if you took the whole condyle, but most of the time you don't need to. So you drill as much as a tailored approach. This is the highly recommended approach. You tailor it according to the case and how much you want to see.
Thank you, Professor Kannan. Is Dr. Jyotish is here? Dr. Jyotish, would you like to comment, Professor? Professor Jyotish?
Yes, Raja. Can you hear me?
Yeah, we can hear you. Sir.
Yeah.
Please come.
I just have a technical doubt about the planar drilling. Do you always do the drilling extradurally, or the initial part extradurally and the final part, final thing is intradurally, or what?
Okay. Thank you for your question. For tumor surgery, I always do extradural drilling, but for the aneurysm, I'm covered. So I always want to confirm the projection or location of the aneurysm before I start drill. And if I feel safe in drilling extradural, I will go back to drilling the extradural part, but via extradural route. But it depends on the projection and the size of the aneurysm and the location of the aneurysm. And if I feel unsafe in drilling extradural, I will come into the intradural space and drill the anterior cranial process or of the canal roof with looking the aneurysm itself.
Okay.
So I use both. Yeah, thank you.
Right.
Thank you.
When you go extradurally, how do you deal with the optic strut? Do you have any difficulty or face any problem drilling the optic strut?
No, I think maybe to drill the optic strut, I use the smaller head of the drill, like a 2 millimeter or 3 millimeter. If we use the smaller drill, I think it's not that difficult to drill the optic strut.
Right. Okay. Thank you.
Thank you, Professor Jyotish, for asking this. I think Professor Otani is here. Professor Otani showed exclusively extradural drilling. Professor Otani, would you like to? Professor Otani?
So, yeah. Thank you, Dr. Professor. So, last one, I would like to ask you about STA-SCA bypass. So, in your presentation, so you just anterior petrosectomy. So, would you please let me know the need to the anterior petrosectomy for the STA-SCA bypass? So because we usually perform the tentorial incision for the STA-SCA bypass, I think it's enough for me to do the STA-SCA bypass. So, but I think, but in your presentation is very wide exposure of the operative field for the bypass deep corridor, but operative field. So would you let me know the need, so additional need of the anticlinodectomy for the STHMC bypass? STHC bypass.
Oh, okay. I think if you drill, if not only cutting the tentorium, if you drill the tip of the petrous apex, you can mobilize the SCA, you know, inferiorly, rosterally, I mean the caudally, a little bit more. You know, you can move the SCA by doing by moving the SCA inferiorly. You can reduce the temporal lobe retraction. It's only probably 5 millimeter or less than 1 centimeter increase, but it's pretty significant, you know, in such deep anastomosis procedure. So you can not only, you know, cutting the tentorium, you can move the SCA from the original position to like a 5 millimeter or less than 1 centimeter towards caudary.
Yeah, thank you so much.
Okay.
Okay.
Thank you. Are there any more questions? Sachin, would you like to come in? Thomas Tommy, are you there? Thomas Tommy was the previous fellow with us. Sachin, are you there? Binoy, would you like to come in, Binoy?
Hello, sir.
Yeah, please, Sachin, please.
Yes, sir. Oh, sir, it was an excellent presentation and very good discussion after the presentation. We had a thorough discussion about all the aspects of skull-base aneurysm surgery. Very good, sir. Thank you, sir.
Thank you. Professor Mohan Sharma.
Thank you for your comment.
Thank you, Sachin. Mohan
Hello.
Sharma. Yeah, please.
Yeah, excellent presentation. Good evening from Nepal.
Hi, thank you.
It was an excellent presentation from Dr. Woya. I have a few questions regarding the use of lumbar drainage. Do you use preoperative lumbar drainage for major aneurysm or?
No.
You do not use?
I do not use a lumbar drainage for any case like this.
Okay. Regarding that blindness, I would like to share my experience with one intracommunicating artery aneurysm. It was a very clean-cut, straightforward ACOM aneurysm clipping. There was no problem. I don't even remember touching the optic nerve, but post-operatively, the patient woke blind, complete blindness, NPL. Then we reviewed the literature that time.
Opposite side?
Opposite side.
Opposite side?
Yeah, I went from the right terminal approach. I always do modified OGO, take out the orbital bar. So it makes the clipping, you know, as you mentioned, to put the instrument and clip applicator. And she woke up one eye completely blind. And then that time I had the opportunity to review the literature, and actually it was reported from Korea also. 2 cases reported from Korea, and their hypothesis was, you know, when you raise the flap and turn the temporal muscle inferiorly and towards the eye, then because of the external pressure, you could actually have blindness. And then from that time onward, we started to put an eye cup, you know, and that was the recommendation. And we had started, once we make the, we put an eye cap, so that if you, even if you raise the flap inferiorly and towards the frontal side, eye will not be compressed. That's the thing I wanted to share with all of you.
Oh, that's a good idea. Thank you.
Thank you, Professor Sharma. But actually, if you look at another angle, the final positioning, where the clip rests, may be touching the optic nerve. And that might have been a cause, because I'm telling this because in the previous lectures of Professor Michael Lawton, he brought out this issue when one of the same question was asked to him, and he also said that he has this similar experience where the patient had one eye blind following clipping of aneurysm. And he said that because of the blade was resting on the optic nerve, he immediately went back in and he repositioned the clip, followed by a recovery of the visual field. So that is also a possibility. And he said that blanching of the vessels of the optic nerve has been shown on ICG angiography when this rests. So one of the solution is that you take a 7080 proline switcher and tag it to the arachnoid of the inferior frontal lobe, so that the clip stays with the lobe rather than it pressing on the optic nerve. So that is one information.
Very good.
Are there any more questions, please? If there are no more questions, then we would like to wind up this session. Thank you, Professor Oya, for such an exciting presentation. Professor Otani for chairing this session. For all the attendees who were great participation, Professor Imad Kannan, Professor Kasadi Kalanku, everyone contributed extensively about their experiences. Thank you very much. We'll meet on next Saturday. We have Satoru Miyawaki, professor from Tokyo University, who is going to speak about surgical treatment of moyamoya disease. So until next Saturday, 6 p.m. Indian time and 9:30 p.m. Japanese time, we would say goodbye to you. Professor Oya, on behalf of the Education Committee and Professor Yoko Kato, I sincerely extend my heartiest greetings for you. Be safe in this pandemic, and thanks for coming. Until then, bye-bye. Professor John Bennett, thanks for televising this. We are really fortunate to have you with us. Thank you very much, everybody.
Thank you.
So until next Saturday, it is bye-bye.